All right. Good evening, everyone. How are you doing tonight?
Fantastic.
Just kind of digging that music.
What a great intro.
That was Sherry's band in the background there, I think.
Yeah, you didn't know I could play all those instruments at once, did you?
Awesome. Well, we are a couple minutes past bottom of the hour, so I think it's time to get going. We want to thank you all for joining our VCSQI winter quarterly meeting this evening. Welcome to all. Hope your holiday season is off to a great start. We will dive right in. We have a couple quick opening intro slides here. Of course, just regular Zoom etiquette. This is an open Zoom meeting, so please feel free to jump in with any questions or comments. Just please be mindful of any background noise, things like that. Where the chat features are, etc. Feel free to call or text Sherry or I if you have any questions. In terms of CMEs, if you could please enter your name in the chat box so we can record your attendance, that would be really helpful. And we will automatically sign you up so you can claim your CME or CEU credits afterwards. You just need to fill out a brief survey on the VCU Cloud portal. Tonight's agenda is going to focus on advances in the data infrastructure, analytics, and applications from the VCSQI registry. So we have a talented panel of clinicians who will speak to VCSQI data and its applications in different projects this evening. But first up, before our featured slate of presenters, we will turn it over to Dr. Robert Shor, the VCSQI chairman, for a welcome and some highlights from the board of directors. Dr. Shor.
Thank you very much. On behalf of the board, I want to share a couple items. First of all, a hearty welcome to two new board members, Mike Brown, who's been in Virginia since the early 90s and with VCSQI for more than 20 years and has been very involved in AKI. So thank you, Mike. Dr. Lancey from Sentara RMH is been working very closely with our hospital readmissions, very engaged, and a hearty welcome as well. We also have a new statistician, Dr. Ting, who we have engaged as needed. And so we're very thankful for that. That really helps some of our projects. An update, we continue our evergreen items, which, as you all know, include Cath review, STEMI registry, and VHAC statewide network, TVT, which is growing. We'll have more information. The other work groups, AKI, shock, and healthcare disparities. This past year, we have added 2 new centers, and we expect several additional centers to be added as we progress. From a financial standpoint, we are doing well. We expect, because of the nature of some of the finances of the last year, to operate at a little bit of a deficit, but well within what we are able to manage for the next year, and that should be offset by some of the additional programs. I did want to take this moment to provide our extreme thanks to Eddie and Sherry for their tireless work over the last year and over many years, without whom we would not be where VCSQI currently is. They have been instrumental. They work collaboratively and complement each other in what they do. And so the board wants to recognize their efforts publicly for just an amazing and outstanding job. So thank you very much. We have more information on some of the finances of the cost data that we're going to be reviewing. We have a great lineup this evening. And so thank you all to the people who are presenting today. As always, if you have any issues or questions and want to just reach out to me, reach out to Eddie or Sherry, please let me know. Mohammed Carter is going to be the incoming chair as of 2023, and it has been an amazing privilege and honor for me to have been in this position, and I will continue supporting as post chair. That's it for me, Eddie. Thank you very much.
Thank you so much, Dr. Shor. So we will dive right into our evening program tonight. Our first featured speaker is Dr. Robert Lancey from Sentara Rockingham Memorial Hospital. Dr. Lancey comes to us tonight from SRMH. He earned his medical degree, completed his residency and training at UMass. He also holds an MBA from Cornell University. Dr. Lancey has been a practicing cardiac surgeon for over 25 years, and he also serves as the chair of VCSQI's readmission work group, and as Dr. Shor mentioned, is a newly elected member to the VCSQI board. Dr. Lancey, it's an honor to welcome you to our VCSQI meeting this evening, and I will give you control of my screen.
Thanks, Eddie. Great. That is me. Okay. I was wondering if I had control, and I guess I do. Well, as Eddie said, I'm from Massachusetts originally, so you can all get your jokes about my accent out of the way now, as you can hear. It's never left me the time I've been down here. And good evening to everyone. I echo Eddie's welcome about the holiday season. I keep thinking the older I get, one of these days it's not going to mean a lot to me, but I'll tell you, every time Christmas rolls around and December comes, I feel like a little kid again. I think it's just the greatest time of the year, and I hope all of you have a real pleasant next several weeks. This is what it's all about. It's really great. So I appreciate the opportunity to present some of the work that we've been doing within the VCSQI aimed at preventing 30-day readmissions. These efforts for me have been really gratifying because we've undertaken it using the expertise of both Eddie and Sherry, along with the VHHA, which I'll get into a little bit more in a few minutes. And more importantly, just real valuable input from people on the phone. Sherry organized these meetings, and we have 20, 30 people calling in from around the state, and just some outstanding ideas. I thought we would try to help other people and give them some ideas on how to prevent readmission. And we've been doing a lot of the learning from all of the great work that's being done out there. And our goal is to sort of compile all this and move forward, as I'll explain over the next 10 minutes or so. I just want to take a few minutes to explain the program and the work that we're undertaking. I think most folks are pretty familiar with what we're doing in readmission work. But I wanted to just present a little background for those who are not aware of it, and very quickly. This is a program that was started by CMS back in the early days of the evolving concept of paying for quality. They recognized that readmissions cost a lot of money, and there was a sense that they shouldn't occur, that it may just be about quality, and they didn't want to be paying for poor quality. So the hospital readmission reduction program was set up by CMS. It was originally designed to foster improved communication and care coordination, specifically engaging patients and providers together for discharge planning at points of transition. And the program was rolled out in 2012 with initially reduction of payments for those in the lowest quartile, which was unfortunate because what seemed to happen is not so much for clinical reasons, but in large part for socioeconomic reasons. Some of the hospitals that were least coped to deal with reduction in their costs and taking care of, many indigent patients were the ones who were penalized the most. So since then, the program has evolved to a much broader scope, the vast majority of hospitals now being subject to penalties. The way that it works is there on the right, it's a rolling 3-year performance period that they measure. Payment reductions are applied to all Medicare fee-for-service DRG payments with a capped penalty of 3% maximum. And up in the right-hand corner, you can see the measures that are being looked at and penalized for, and in our realm, acute MI, heart failure, in addition, COPD and pneumonia. And more recently, over the past few years, the addition of 2 orthopedic procedures, as well as coronary bypass grafting. So this is now the 10th year of the HRRP. And just to give you some quick background data, CMS is now, for that fiscal year 2022, will penalize nearly 2,500 hospitals, or 82% of the hospitals in the country, for high 30-day readmission rates. 39 hospitals were hit with a maximum penalty. And if you know much about healthcare finance, you know that a 3% hit on your revenues is a significant amount. In some states, such as New York State, you know, the margins are like 1 to 2%. So this can be you know, pretty onerous when, you know, 40% of your revenues and Medicare payments are hit with a 3% penalty. Average penalty across the board is about just over 0.5%. And it's reaching its goal. Medicare is estimated to save over $500 million over the next fiscal year because of this program. So what their idea originally was to attack the factors that are impacting readmission. They thought it was to some degree poor quality of care, poor transition periods in getting patients to an outpatient setting involving discharge planning, medication reconciliation. So the premise being that improvement in those areas will reduce readmission rates and thus cost to Medicare by improving the quality of care, improving communication with patients and their caregivers, good patient education, et cetera. Those of you that have been with the VCSQI for a while know that there was an initiative that started around 2015 and ran into the next year or year and a half, in which site visits were run, meetings were pulled together, and they developed this very nice 3-page protocol that was aimed at reducing readmissions. You can see, I won't read obviously all this to you, but you know, those familiar with it will know that there was a lot of work, an outstanding effort by the group to really take a deep dive into both the practical and theoretical causes of readmission. From what I understand, this led to an initial decline in readmission rates, but unfortunately, the adoption of the protocol was spotty at best, and rates, you know, sort of continue, as we'll see in a future slide, up to 10%, 9-10%. So the idea was that maybe we should revisit this and not just look at revising the protocols or you know, I guess you could say probably updating the protocols and getting more input from around the state on what works and what might not work. But also at the same time to try to figure out why there wasn't adoption. And I think some of what we understood from that was that, you know, in part, some of these initiatives cost money and personnel, and you know, we are all kind of stretched for time and people now, and it just became somewhat inconvenient to adopt some of these, and some of them were quite good. We heard one example of putting iPads at rehab centers and being able to communicate on a daily basis and even take a look at the patients that are at rehab centers, but I thought was an outstanding idea. But iPads cost money, and it's not something that every program could do. So as we sort of took this journey, we tried to look at turn over a lot of stones and try to see, you know, what worked in the past, what didn't, and try to develop an even better protocol. Because the problem still exists. You can see the data here that Eddie and Sherry put together. This is the latest data for you know, Q3 21 to Q2 22, 30-day readmission rates for isolated cabbage. You can see at the top there the VCSQI is about at the national average. The STS adult National Cardiac Surgery Database rate about 8%. And you can see in the graph that there is a lot of variation, you know, between the low volume groups, between the medium volume groups, and within the high volume groups to some degree, and even within hospitals, where, you know, one hospital here with a rate probably around 2.5% up to 20%. Of course, that's in somewhat probably because of the low volume and what that does to your percentages. But still, you know, there is a lot of variation, and when you have that much variation, standardization seems to, you know, kind of pull things together and help out with that. And I think that's one of the things that what we saw as one of the opportunities moving forward. Eddie also pulled together sort of some of the non-clinical data on readmission. You can see here, looking at race and gender, there seems to be a little bit of a trend toward more common readmissions in females for CABG. I think, you know, that may stem in part from the fact that, as we all know, coronary artery disease you know, attacks females at a more advanced age than males, and that may have something to do with it. But, you know, some of the the disparities are quite marked, including in the Hispanic population. Also broken down by weight, so we see that, you know, different rates and different weights, and I think we're getting, you know, the sense by looking at these numbers that there is a growing rate within folks that are morbidly obese or obese. And I can tell you that we did a study with Columbia looking at, you know, about 5,000 patients about 10, 15 years ago, and trying to develop a risk score. And one of the most dramatic and most powerful predictors of readmission for us was obesity and morbid obesity. So I think that you know, goes along with what we had seen in the past. So over the past 6 to 8 months or so, Eddie, Sherry, and I have been working with the VHHA, a group that has some tremendous data on social determinants of health. And what we've been trying to do is evaluate the present rates at the participating hospitals, that graph you saw a few slides ago. And then we took a look at the past initiatives along with the adoption rates on interventions by different programs. Our goal was really to, not only cast a wide net and seek ideas on readmission prevention from the participating programs, but also to use that data in developing a risk score that we could this time incorporate social determinants of health and capitalize on the expertise of the VHHA. It's interesting that I jumped in readmission work early on, 15, 18 years ago when this first started to really roll out, and we started to get an idea this was going to be a coming thing. And I was surprised that the whole idea of non-clinical factors was really dismissed at the beginning. And as I mentioned, it had grave implications for hospitals who served indigent populations, because I think Medicare, after a while, recognized that this isn't just a quality issue, that indeed this has to do with a number of things, including access to hospitals, access to primary care doctors. And again, I think to some degree, cultures in hospitals in terms of the rapidity with which patients who present to the ED are then admitted. I think all of these play into it. So it's not just simply that, bad care is being delivered, so there needs to be more readmissions. In fact, I presented at the STS one year on this, and the first question that came up was a challenge saying, well, what do you think about good readmissions? And it was a concept I really hadn't had, that there actually are some people that need to be readmitted, that, are sick at baseline, and we couldn't do everything for them while they were here, and they need to come back in the hospital. So there are some folks that need to come in. We just can't say, outright that nobody should be readmitted and seek for a 0% readmission rate. So again, our goal is to develop a risk score incorporating social determinants of health, so access and target these modifiable clinical risk factors. And I think most importantly, and I'll come back to this a couple of times, we really want to identify and target the high-risk patients with interventions that are both cost and labor intensive, so that we're not applying them to everybody, particularly those who really don't need them. You send a 62-year-old patient home with good social support, good EF, home after 3 or 4 days in the hospital with an isolated cabbage. Readmission risk on that patient is extremely low, and they don't need all of the interventions. But certainly some other folks that we can identify do need that. And then, of course, I think the key is, I've always say innovation is easy. It's the implementation that's the hard part. And sustainability is impossible. So I think what we need to do is to develop a program and a process and protocols that we can disseminate and really get good adoption. And I think we're hitting on that in large part by getting folks involved in the program early on and building it themselves, rather than saying, here's some protocols, bring them to your hospital and adopt them. Rather, we're building them ourselves with the people that are going to be implementing them and adopting them. And I think that's going to be a very effective method moving forward. And then, of course, the key to it all is to then track the results and see if what we're doing is actually having an impact on readmission rates. So this is a really busy slide, and I won't go into the details, and it's coming up worse on my screen than I thought it was. And it's a disservice to Sherry, because this one slide has probably cost her about 3,000 person hours over the past 8 months putting this all together. And what you see here is that we've gone through to the organizations and said, what do you do? What are you doing now? And it gave us an idea of, what was adopted in the past to some degree, but it also gave us an idea, as you can see in red, of some outstanding ideas that folks do to prevent readmissions that work well for them. Circle back calls with rehab and skilled nursing facilities. If you think at first blush sending someone to rehab, what should be their readmission rate? It should be extremely low. They're in a nursing care center, and yet in some programs, they're very high. So you need to work with those folks. You have good skilled people out there. They can keep an eye on your patients and work with you to keep them out of the hospital. A lot of places that do interdisciplinary review on a case-by-case basis. And a number of other initiatives. I won't go into the details, but putting bracelets on patients and pre-op visits with physical therapy, and just some really neat ideas that we heard as we went through the system. So what we did put together, what Sherry put together, I'd love to say I did it, because it was a tremendous amount of work and a great help to the whole efforts. She pulled together the idea of what people are doing now, what percentage of programs are, for instance, doing risk factor identification, which are doing patient and family education. And you can see in the next few slides, the red ones are real opportunities. We're not even looking at economic hardship areas and VHA data in 2/3 of the programs. Really not successful in the bottom here, looking at evaluating patient before surgery. What's going to be at home? How are you going to do? I sent a patient home several years ago, and they came back in 3 hours later to the emergency room because he couldn't walk up the 5 steps to the house. And it was kind of like, egg on my face. And we started making sure everybody could walk stairs before they go home. Sounds kind of simplistic, but those are the kind of things that will get in the way of, successful return home and not return to the hospital. We looked at inpatient data. A lot of people doing, fairly well acknowledged solutions to prevent readmission. The same with education of families and patients. One place I worked before, hospital pharmacists actually sat in the ICU, and we had a brown bag program. We had them, patients bring all their meds in a brown paper bag, and had the pharmacist go through them and throw out all the empty bottles and really trim down the medication list, and did some education with patients. Found that extremely helpful in trying to cut back on readmissions and also just for regular care. Post-discharge, daily calls a lot of folks do, having same-day access to a CT surgery clinic. So again, I would argue, although I wasn't part of the VCI back in 2015, I would argue that before 2015, a lot of these would have been red boxed and have low rates. And thanks to the work they did before, we can see where a lot of people are now at 100% of the places that we surveyed in terms of involving and invoking these interventions. And there's some additional interventions. Some of these are more of these in red because they're not as common, but they're ideas that we had from the network: setting up a minor procedure room for pleural effusions and wound care, designing a pop-up in the EMR and the ED. So when a post-op patient comes in, the ED doc immediately knows this is a cardiac surgery patient, so that instead of just doing the routine EKG, echo, chest X-ray, troponins, and admitting him to the hospital, you get the cardiac surgery team involved from ground zero. So in trying to work towards the risk scores and risk assessment and saying, are we going to sort of, build a new mousetrap and take a look at assessing some of these higher risk patients, then designing interventions to them. We did a pretty deep dive into the literature, and I have to admit that it wasn't intended to be a self-fulfilling prophecy, but it indeed was. And that if you look at the scores of papers that have been written about this, there are not consistent predictors of readmission throughout. It would be nice if there were, and we all knew, what led to readmissions. But as I'll show you in the next several slides that I'll go through fairly quickly, each paper that's written seems to come up with new predictors of readmission. So instead of having a solid 5 or 6 we can apply to all patients, it turns out, there were close to 30, and they're not consistent throughout the papers. So this study that I have up on here, that was the first one we'll take a look at, use the New York Cardiac Surgery Reporting System, which I'm familiar with. I was in New York State for a while, and they look at different risk factors in a large number of patients in this system. And what they found the predictors of readmission to be was an abnormal serum creatinine at discharge, unplanned reoperation during the hospitalization, and then government insurance, Medicare, Medicaid patients. Let's see, doesn't seem to be moving. There we go. Okay. All right. Okay, so this next study here was done by Joe Sabick and his colleagues. Joe's out of the Cleveland Clinic. They took a look at over 135,000 coronary bypass operations using the National Readmissions Database, and they found the predictors to be old age, females, end-stage renal disease, long length of stay, and again, government insurance. This next analysis looked at over 2,500 CABG patients. The 5 clinical risk factors they found were old age again, but now diabetes, history of congestive heart failure, low serum albumin, and a prior MI. So you kind of get an idea that, one size doesn't fit all in these risk scores. So the question is, how adaptable and adoptable are they? This is a more recent study that looked, again, at the number of patients undergoing CABG using the STS predicted risk of mortality scores. And what they found is that a higher PROM score, greater risk of readmission, lower ejection fraction, history of heart failure, government insurance again. I'll just zip through these. This is another study that took a look at the National Readmissions Database, nearly 300,000 patients, so a pretty powerful study. 12% readmitted within 30 days, and these are all the predictors of readmission, female, gender, chronic renal failure, COPD, and then some of the post-op events, acute renal injury, AFib, pneumonia. Interestingly, again, discharge to SNF, which I talked about before, and government insurance. So paradoxically, as I mentioned before, the program started off, HRRP started off looking at the clinical reasons for readmission. And it turns out one of the only factors that predicts readmission throughout most of these studies is actually a non-clinical factor, and that is Medicare, Medicaid insurance patients. This is a study out of Ontario, Canadian study. They found post-op sepsis, post-op MI, long length of stay, again, as predictors of readmission. And finally, in one of the more recent studies published in the Annals of Thoracic Surgery by our own local Virginia colleagues, STS database was used to look at nearly 20,000 patients. They identified chronic lung disease, race, type of operation, post-op renal failure, long length of stay, and discharge location. Again, we mentioned SNF before. So again, we start to wonder whether it's only clinical factors or others at play. So in wrapping up, what have we learned? Well, a couple things. Number one, there are some real key and easily adoptable interventions that anecdotally and theoretically are important in preventing readmission, including pre-admission discharge planning, a prehab program that UVA, for instance, has running. And then sort of my own pet peeve, the ED, and I put a little slip and slide up here because this is what I think my patients do when they come into the ED in terms of admissions. They come in the ED and they just slide right down, give your insurance card, get a CAT scan, and get admitted. Because it's very, very common that once they hit the ED, there is a very low threshold for admission. We addressed this in the past with a number of things. Number one, the pop-up banner that I mentioned so that the ED physicians knew that they had been recently discharged. We actually went down to the ED and told the physicians down there, look, if you call us when they come in, we'll come down and evaluate them. They love that. They said that's a great, if you've ever been in a busy emergency department, that was music to their ears. And they would call us, all time, day and night. And we'd go down and take a look at them. And I can tell you, we headed off a lot of unnecessary readmissions by doing that. Red wrist bracelets that have your name and number on it, sort of like the Live Strong bracelets, so not something you can pop off. It's very visible. Patients in the providers in the ED see it when they come in, and I really think it's sort of like in marketing, you give someone a hat that has the name of the company on it. It's kind of like branding a steer. You wear that hat around. It's free advertising for your employer, and it kind of brands you as a member of it. I think the same thing goes with the red wrist bracelets. We put them on and we tell them, look, you're part of our family for the next month. I tell them, we're not a medical home, we're a surgical home. You're ours for a month. Anything goes on, you call us, don't call primary care, don't go to the ED. And it works. People look down at their wrist and make a phone call and give us a call. And I know that's been it's a simplistic solution, but it does work. And then some of the new process ideas I mentioned, developing a risk score that takes into account the social determinants of health. The work that VHA does is just outstanding. They have just a gold mine that we can look at in terms of how they address this. And I think that's going to be a real keeper for this program that we're doing and for these interventions, is to really crack that barrier and make that an important part of our risk score. And then other ideas, virtual visits at rehab centers and whatnot. I know it's been kind of quick, but I didn't want to monopolize the time. I would like to leave it open give more time for questions, ideas, and suggestions, because I found in our meetings in the past that the less talking I do, the more I learn. So I'm going to just throw it out to the group to see if anybody has any questions about what we're doing, any ideas to throw out here real quick that I'll write down, and any suggestions as we move forward.
Hi, this is Alan Spear. Thank you for a very enlightening and thoughtful presentation. I think the one thing I was struck, Dr. Yancey, as you were talking is, yes, there has been a lot of work done with these different protocols, but I don't think readmission is any different than bleeding or renal failure, in that we need to continue to review the protocols on a much more frequent basis with our whole team. I don't know about your institution, but we've now got almost 50% travelers in our critical care units and step down units. And they, of course, can't be expected to to really have a firm understanding of what these types of protocols that are invaluable are seeking to provide, it much less the turnover of our regular staff. And in our area, military, governmental, the turnover rate is about 25% or higher annually. So the point is that because we've got a good, thoughtful protocol doesn't mean that it is going to be consistently used and is going to be available for folks to even know about it. And my plea is that for all of this good work that was done, not only in this, but these others, is that we just remind our staff quarterly, every 4 months, and review this with them so it is much more readily understandable, because otherwise it dribbles off the court.
Yeah.
Thank you again.
Those are great comments. I think you're right. As I mentioned, it's, innovation is easy. It's implementation that's hard, and sustaining it, it's impossible. And I think your comments are well founded, particularly in terms of travelers. I think in the past we've toyed with ideas. All this is, for physicians, it can be onerous, but having a checklist in the EMR that has to be, filled out before they go home, it can be, for all of you who get our BPAs and our blocks, it sounds, just more work to do. But in a way, particularly as you point out with travelers, it may be the only solution to really standardizing the care we have.
Do you have any comments about the use of advanced practice providers in the outpatient setting, actually going to rehab centers or visiting the patient homes to be able to be proactive in management?
Yeah, they've all gone home, so I can comment on that. I think it's a great idea. I think there was a paper published in the Annals several years ago that actually looked at this, and they had PAs going out to patients' homes, and it worked wonderfully well. My mantra is that the only sure way to prevent a readmission is to not discharge someone. Then you'll have a 0% readmission rate. So the idea is that if you can, to some degree, mimic the hospital at home, and what better way than to have visiting nurses, PAs going there, and looking at the patients and following them closely, and daily phone calls for those in heart failure, some telemetry monitoring and whatnot. But I think it's a great idea, and I can tell you that at a hospital I was at in Virginia that was not in arguably one of the better parts of town, we toyed with the idea, but my PAs just, they essentially wanted combat pay. They said, look, I can't go out there wandering our neighborhoods going into these houses. there are shootings out there, every few days, and I think that was a little bit overdrawn. But your point's well taken, and it's been like I said, I believe it's been shown in a paper in the Annals that it does work to send the PAs out. Okay, well, I remain open to any ideas and suggestions as you hang up at the end of the night time and run into something on the wards tomorrow, and you think of something, feel free to send it along. We really want to cast a wide net and get this right and move it forward. So always open to ideas. Now I get a real delight. I get to present the next speaker. And oops, they switched it already. Well, anyways, Peter O'Brien. Peter, I wrote about you, so I'm going to try to memorize. It didn't come up on the screen, see how well I did. You did your residency in cardiology, infant cardiology at Wake Forest. You've been on the American College of Cardiology daughter balloon task force. I know you have some leadership roles down at Centra Health in terms of the acute MI program down there. So I guess my only comment was, there's probably nobody better to talk to us about STEMI care, shock care, and about the chest pain and CathPCI databases than you. So I'll turn it over to you.
Fantastic. Thank you for that kind introduction, and great talk. I'm here scribbling down notes already about, I watched our readmissions bump again last quarter, so I'm listening with great interest, and I think we may be reaching out to you again, but wonderful talk and very timely. I now have control, I would imagine, the slides. So I'm going to go ahead and get started again. Thanks to Dr. Lancey, and thanks to all of you for tuning in tonight. I'm very excited to come back and update you on the activities of the Virginia Heart Attack Coalition, Cardiogenic Shock Initiative, and VCSQI, and then specifically present more of our STEMI related data. And let me see if this will,
Yeah, try clicking on the Zoom window just a couple times. It should
I'm sorry.
try clicking the Zoom window just a couple times. It'll prompt you to, there you go. Yeah.
Yep, that should work. So I have no relevant financial disclosures. Well, I think a lot of you know who we are. We have been around for, gosh, next year will be our 15th year in existence. And I think that our mission statement continues to sum up our passion and really our reason for being, and that is to work collaboratively to improve the systems of care for the early recognition and treatment of all Virginia residents having heart attacks. And that's really what animates us and continues us to give us that fire in our second decade of existence. And if I had one slide to kind of show you the spirit or the zeitgeist of VHAC, it would be this one right here. This paramedic holding up a pre-hospital EKG with a pretty obvious inferior STEMI, to remind me to tell you that even though VHAC was started in 2008 by myself, Mike Contos, and David Bird, a couple of cardiologists and an ER physician, sounds like the start of a joke there. Even though we started this, this is not really a cardiology or ED owned initiative. This is a very diverse group of stakeholders because, as many of you know, STEMI care is a team sport. And the only way to grant access to rapid reperfusion, to reduce that time, or as I like to say, to get grandma with her inferior STEMI from her living room to an open artery in the cath lab, the only way to do this is to fully engage, support, work with EMS, with ED staff, cath labs, administrators, and really a fairly diverse group of stakeholders committed to the same idea. So I want to give you kind of an update. I could speak for an hour about what's happened over the past 15 years, but I want to just, I think a lot of you now are familiar with who we are and what we're trying to do. So I want to bring you up to speed on what's been going on. Most of our work really goes on day to day, but culminates in our, this is kind of a quick plug for these meetings, the third Thursday of every month. We bring the regions together to present our data, to talk about meeting activities in our own regions. We collaborate and work pretty closely with EMS throughout. They're present at a lot of these functions and at these calls, and we talk about what's happening in the pre-hospital phase of care, some of their challenges, successes. One of the hot topics recently has been ESO, which is a electronic patient care record that I think is ultimately going to revolutionize the pre-hospital phase of care, both in terms of how we get the data, how that interfaces more seamlessly with the hospital, and how that ultimately will allow us to improve that phase of care. So it's like all things IT, it's been a little bit bumpy and a little bit slow to roll out. It's more in use in some regions than others, but I think ultimately it's the tide of the future. We continue to discuss and plan our regional and statewide educational activities. We are very much, again, about engagement, about process improvement, and part and parcel to that is education. We put on twice a year a didactic conference that we've done remotely since over the past 2 years or so. And these have been, I think, very successful, hopefully are really interesting and of use to our members. We've done topics as varied as who do you take to the cath lab after a cardiac arrest, pulmonary embolus, cardiogenic shock, and those sorts of topics. We continue to collaborate outside the boundaries of our organization with EMS councils, with individual hospitals, with the American College of Cardiology and other like-minded organizations. And I want to put in another plug tonight for our new revamped website, which has a different address. It's www.vaheartattackcoalition.org. And this is the first of many times during my talk that I'm going to thank Sherry White and Eddie Fonner for the incredible work that they've done. Sherry has worked nonstop on this website. There's still more to go, but I would check it out. We want to be a stopping place and a clearinghouse for communication, for education, and for all things STEMI and shock in the state of Virginia. One of the great things that has come from this is that, you know, we spent many years developing the relationships, the infrastructure, the implementation. for our quality initiatives. But the vision was ultimately that we would be more than just STEMI, that we would be a more inclusive, larger QI tent, if you will. That was part of the reason that we joined with VCSQI. But it also, I think, served as a springboard for a wonderful idea that Dr. Benham Tarani from Inova Fairfax brought us a couple of years ago. His vision was to do for cardiogenic shock what we were attempting to do for STEMI, and that was to regionalize and improve care. Now, VHAC took many years. Rome was not built in a day, so all of these things take a while to really get started and get going. But I think already we've made some concrete progress. The first thing we did was we asked the member hospitals to more or less dust off their shock protocols and update them and bring those to the table. I think we all have, we're veterans of chest pain accreditation and many, many other cycles like that. And we write lots of different clinical decision pathways and protocols. And some of those become very useful and others really get stuck in binders and put on shelves. I think we've all seen that. So we asked hospitals to take a critical look at their shock protocols again and to really try to make these living and breathing documents, things that guided care day to day for our shock patients. We also work to educate our data managers and each other about how do we identify these shock patients early and how do we identify them per quarter from the registries. And just as a point to note, we're talking about ACS or myocardial infarction shock. We're not really dealing with the other phenotypes right now. And then again, we wanted to make sure that we've identified these patients early in the ER, in the cath lab. We know coming out of every quarter in the registries who our shock patients were. And we want to make sure that those shock protocols, again, are active things that we're applying to those patients. So we decided to first look at two performance measures. We're not quite at the stage yet where we're looking at mortality and outcomes measures. And we settled on cardiac power output and lactate. So, we've had a lot of great suggestions about other things that we could look at. There's many different variables or data points in our shock patients that are important and impactful. But one of the things that we learned with the Virginia Heart Attack Coalition many years ago is trying to regionalize care across a region or the entire state is maybe not complicated in terms of its goals, but it is very, as Dr. Lancey alluded to, you can come up with great ideas, but implementing is really where the rubber meets the road. So we figured out that settle on the highest impact measures and then get everybody laser focused on those and don't ask for too many things all at once. So it's not rocket science, but it's kind of what's worked for us and we hope what works for the shock initiative. And then we're also kind of the informal sort of support groups for each other and a place for us to bounce ideas off, find out what's happening at other hospitals, future directions. And ultimately, we'd like to have formalized journal clubs and ways to disseminate more of that information. And this is just an example of some of the didactics, some of the educational programs that we put on. This is one going back a couple of quarters, but this was, an excellent program that brought in a lot of experts, and I think hope was of a lot of interest to our members and the attendees. Stay tuned, by the way, our next one is in April, and we have not settled on a topic yet, but stay tuned and hopefully we'll get some of you involved in that as well. The other thing that I'm very proud of, and I want to really credit Eddie for running these, is our data manager work groups. Now, as I interact with abstractors, data managers across the state, I'm always impressed by the experience and the knowledge, but also the complexity and the challenges of doing these jobs well. There are multiple, too many to count, data points to enter into these registries. And we know the old adage, garbage in, garbage out. If we don't have talented, supported, experienced people doing this kind of work for us, the data that's coming in, if it's not good, what we're getting out is not going to be a product that's really going to impact our QI efforts in any meaningful way. So this is the third Wednesday of every month, another meeting plug for those of you interested. And it brings together these folks along with, some of the docs like myself. We try to get on these calls when we can, just to, really to learn myself, but also to answer questions and supply some of the clinical reasoning. but it's a chance to discuss questions, issues, and other topics germane to registries and quality improvement, and sometimes helps us formulate kind of a group question that we bring back to NCDR, get with the guidelines to get some further clarification. So keep those in mind. Data manager work groups, let folks at your institutions know if you think that this would be of interest to be helpful for them. So it's been a great ride, and I think I've been blessed to work with some tremendous stakeholders and people who have really been with us for over a decade and have been committed to this work. And if you, again, keeping that axiom, keep it simple, set your goals, and then apply that laser focus. We have done that to reperfusion time, median first medical contact to device time. And you can see that over the course since 2010, I'm sorry I didn't use the right colors for the legends, you really can't read it, but this is 2010 at 90 minutes, all the way down to 75.8 minutes is the median FMC to device time from 2010 to 2017. But as you'll notice, that's where the data stops. And that's where we suffered a fairly big setback in our organization. That's when the American Heart Association pulled out of the Action Registry, and we no longer had a benchmark unified data set where we can do apples to apples comparison of STEMI centers across the state. So we were a little bit in the wilderness for a year or two trying to figure out how do we replace this, how do we get our feet back underneath us, and how do we get this going again? Well, that's where VCSQI came in. And now I had been involved in VCSQI. I think Dave France, one of our surgeons at Centra, talked me into going, gosh, over 15 years ago. And I always enjoyed the meetings. I was always very impressed by how far ahead they were of a lot of quality efforts in terms of the data, presenting that data to their members, making it actionable, publishing. So we were always a little bit envious of VCSQI in terms of that involvement and infrastructure. They were natural folks to turn to say, hey, is this something you think you can help us with? Is there a way for us to, we still have hospitals doing CathPCI, we still have them doing Get with the Guidelines, this work is going on. How do we pull this into a regional, a statewide database again? And fortunately for us, through some of the magic that Eddie and Sherry are able to work, this came together. Again, this has been, this stuff doesn't happen overnight, so they have been at this for several years, but we are now up to 17 members that are sharing CathPCI, chest pain MI data from NCDR quarterly. We have several more centers that are awaiting uploads. We also are going to be able to get with the guideline hospitals on board. We're in the final stages of that module becoming workable with our vendor Armis. So are we where we want to be yet? Not exactly. We have, I think, 43 or 45 PCI centers. They actually come on and offline every couple months in the state of Virginia, but we're somewhere in the 40s for PCI centers. That's our dream, is to have all 42 or 45 centers participating in the STEMI database. And I think then we'll have a fully robust and operational way to benchmark performance. So I am going to show you some of that data, which I think is very interesting. I'm going to explain a little bit of the background as to why we're following these 5 measures. As I said earlier, we try to focus on the high impact things. So if we're looking at that continuum of care from grandma's living room until TIMI-3 flow in the artery in the cath lab, there are lots of different time variables and things that you can measure along the way. So we try to focus on those things and say, okay, if we make this one better, if we change this, what will ultimately be the impact? So we pick, again, those high value targets. The other thing we do, or we're able to do now, is we're able to report out by region. So as a bit of background, the Virginia Heart Attack Coalition is loosely organized around EMS council districts. So there are 6 regions in the state of Virginia. We have 5 of those ready to report. One of our regions, the central region, is not quite participating yet at the level that they can report out this data, but that should be coming. So what do we look at? We look at median door in, door out for the transfer hospitals. Those are the non-PCI centers, because we're looking at patients that show up at a PCI center, but also patients that show up at a non-PCI center and get transferred to a PCI STEMI center. We're looking at transfer time between hospitals. We're looking at first medical contact to device time based on a percentage under 90 minutes and also a median FMC to device time. And then finally, pre-hospital EKG usage, because as I showed you in that first slide, none of it happens really without that paramedic in the field getting that pre-hospital EKG. So how are we doing over this reported time period of Q3 2021 to Q2 2022? We're doing okay in door out. This is actually really hard to get done under the goal time of 45 minutes, especially for some of our rural centers, because we have one hospital that's 70 miles away, and on a good night, they're going to be waiting for the helicopter for a long time. Those hospitals get thrombolytics, but that's kind of a story for another talk. But there are geographical challenges and differences. We look at median transfer time between hospitals, not as much of a difference as I would have thought, but does reflect some of the geographical diversity. We're doing relatively well in percentage under 90 minutes. Our goal is greater than 90%. We're at 88.3. First medical contact to primary PCI, we're doing surprisingly well at 73 minutes. And I say that because of the all the challenges that we've faced as a healthcare community over the past 2 years. And then pre-hospital EKGs have improved dramatically. This was a big push of VHAC back in the day. We worked with the Office of EMS, we lobbied, we worked for grants, and improved the percentage of vehicles in the state of Virginia from about 60%. It was pretty abysmal. It was actually less than that, up to almost all vehicles in the state of Virginia, rescue vehicles, now have pre-hospital EKG equipment. So we may need to retire this metric because it's almost universal at this point. We're doing pretty well. By the way, green means you're exceeding the VCSQI average. White is you're statistically on par with that, and that kind of orange color there is less than the VCSQI average. I won't go through all of these, but this is to show you the power and flexibility of the reach of the STEMI database at this point. We can break it down by your hospital. We have a secret code, but we can give you your code if you want to see how you stack up against other institutions. And we can have other fun with this and nerd out on various STEMI things. We can show you the trend in median FMC to device time in the different regions. I think it'd be interesting at some point to sort of stretch this out over the years and trying to get a sense of patterns, regions that are on the rise and regions that are having trouble. I think yeah, there we go. All right, well, I want to show you some of the data now that Eddie has been kind enough to separate out. The data that I'm going to show you may look pretty familiar, but now we're just going to focus on the STEMI patients for bleeding, access, length of stay, things like that. So hang on to your hats here. So this is the procedure. Before I get started, this is the procedural volume by quarter, which surprised me a little bit. These are for the participating hospitals, obviously not the entire state. It surprised me because I would have thought with the multiple shocks to the system since early 2020, COVID, the labor shortage, and for a lot of hospitals, including ours, the IV contrast shortage, I would have thought there would have been more variation, but we've held fairly steady in terms of volume. Just a little bit of definition or measure specifications and housekeeping. We're going to look, when I show you these slides, there's going to be a gold bar for Q3 2020 to 2021, and then we're going to compare it next to a blue bar, which is going to be the third quarter of 2021 to second quarter of this year, which was the last quarter that's now fully published. We use standard ACC metric definitions. We classified programs by volume according to the number of PCIs per year. So low is considered less than 250 PCIs a year, medium is 250 to 500, and high is greater than 500. And statistically, if there is a plus sign next to the hospital, it means that they're statistically significantly above the VCSQI average. If there's no plus sign or anything else, it means they're basically on par with the average, and then an asterisk means they're below the average. And this is what it'll all look like, which I think I've already explained most of the fine points. But if any of this looks weird or confusing, just let me know. I'll stop and answer questions. So looking at radial access site for STEMI, this is interesting. Again, to break this out now just by STEMI, not all PCI. You can see that we're about 70-30 in the state, which depending on how you look at it, I think is a good thing. I've watched this data in NCDR in my own hospital over the years, and it's been nice to see the percentage of radials gradually increase. But you can see there's a fair amount of variation between hospitals. I mean, we have even some high volume centers that are still fairly hardcore femoral. Obviously, without getting into all the data, I think radial is the preferred route, but you can't always do radials on every STEMI. Sometimes they're too sick or there's other vascular issues, but certainly that is the goal. This is bleeding. Now, this is observed versus expected for PCI for STEMI. And just to show you there, the average, the green bar across the graph, there is the VCSQI average. So 0.65 means the ratio of observed to expected, which means we're actually doing better than would be expected by, at least according to our patient population, our documentation, what have you. The observed rate is 5.5%. Getting a little sluggish, maybe. There we go. So we then broke it out by femoral versus radial. And we dug a little deeper in the raw numbers I didn't put up there, but they are 4% for radial and 7% for femoral. So basically about what we would expect. Eddie, I hope I had that right from what we discussed. But as you would imagine, it's less bleeding with radial, more bleeding with femoral, and this is over the past 4 quarters. This, along those lines, looks at packed red blood cells, whole blood transfusion by hospital for PCI, for STEMI, and you can see quite a bit of variation with the VCSQI average of 3.5%. This is the quadruple endpoint MACE, if you will, of emergency CABG, stroke, death, and emergent target vessel revascularization. The VCSQI average is 7.8%. I mean, it does reflect that this is a sicker population, and you can see a good bit of variation between different hospitals. Now, one thing I hadn't mentioned as I go through, without getting down into too many details on every slide, is you will see in some of these slides, you will see the blue bars are bigger than the gold bars. In other words, the most recent 4-quarter average is better than the preceding 4-quarter average. So that's a sign of progress. This is something else that's interesting, fluoro time, if you're thinking about radiation safety. Where you do not see any data, it's because the hospital did not have any cases over 60 minutes that quarter. Radiation safety is a whole different talk, but fluoro time is a fairly coarse measurement of that. There are other ways to measure that, but this is at least a start looking at radiation safety and quality. Average length of stay for the state participating organizations, 3.21 days, which is about what I would expect. We don't normally send our STEMI patients home much sooner than 48 hours. We've had a few low-risk patients we've sent home the next day. And you can see that there seems to be more uniformity between different institutions based on this data here. I just have a few more slides to show you, but the next 3 slides will be about acute kidney injury. This is the observed AKI by hospital. This is not observed versus expected, but just the raw data. The VCSQI average is 12.5%, and you can see quite a bit of variability among different hospitals. And this is now observed versus expected. Again, we're a little bit better than one would expect. It's 0.91 with an observed rate of 12.5. And then we broke it down by radial versus femoral. I don't want to speculate too much why this is. There's probably, even with there's certainly going to be elements of selection in terms of how sick patients are, how their access site is selected, what other factors come into play. But one could posit that if you have less bleeding, then you have less other bad things. We know that bleeding leads to a cascade of negative clinical effects that can lead to multi-organ involvement, which can include AKI. So I don't want to speculate too much, but I thought this was kind of interesting to look at the difference between access site and rates of AKI. And then in the hospital mortality, observed versus expected, the observed rate statewide average is 6.5%, and the ratio there is 0.83. So again, a little bit better than what's expected. And this is just to show you that there's lots of ways to slice and dice this data, not only for your program, but also for your operators. We can actually give you the mean door to balloon time for individual operators, which is at a median of 61 minutes, which is pretty good. But if you look at the range by operator, it's 37 to 111 minutes. And the interquartile range is 44 to 83 minutes. So you can see there may be some opportunities here with individual operators. So obviously, I'm passionate about STEMI care. It's kind of what, you know, keeps us going. We're dedicated to this. But over the years, there may have been a bit of complacency. You know, the Door to Balloon project was unveiled in 2006, and Mission Lifeline followed closely thereafter. And although people don't say expressly, sometimes I kind of get the sense, well, didn't we sort of figure this out before? I mean, you know, isn't Door to Balloon something we're all doing a great job with? Well, you know, isn't this basically kind of yesterday's news? Well, the answer is unfortunately no. And this was a paper that just came out in an electronic publication by Jamie Jollis and the group at Duke that started the RACE program, which was really the first statewide STEMI system of care, and a lot of where we drew our lessons and inspiration from. And what they did was they looked at the Get With a Guideline registry over 3 years, 114,000 patients. They looked at time to treatment, adherence to system goals, mortality. And what they actually saw was we were getting slower and not faster. Time to treatment increased from 86 to 91 minutes, and the mortality went from 5.6 to 8.7%. Now, some of that was likely due to COVID or the strains on the healthcare system, but some of these trends were actually seen before early 2020. So I think that's pretty thought-provoking. System goals were not met in most quarters, and by that I mean first medical contact to cath lab activation, what we call our first medical contact to decision time of less than 20 minutes, first medical contact to balloon time less than 90 minutes, transfer time, and this is a patient that shows up in a non-PCI hospital less than 120 minutes, and door in, door out less than 30 minutes. The area that we struggled, I say we as a nation struggled with the most, was the transfer PCI patients. So first medical contact to the door of a non-PCI center, to the STEMI center, the PCI center, to an open artery. Should be done in less than 120 minutes. We were hitting that, I say nationwide, hitting that 17% of the time, 1-7. So that's pretty scary. And obviously that shows that we have a tremendous amount of work to do. And not surprisingly, when the goals were met, patients did better. You know, first medical contact balloon less than 90 minutes, the odds ratio for mortality 0.40. So incredible bang for your buck in terms of patient outcomes. And again, this is baked into the guidelines. This isn't just, wow, this would be nice if we could do this better. This is as fundamental as anything else that we do when we take care of MI patients. Aspirin, cardiac rehab, smoking cessation, what have you. It's a class 1 indication to regionalize your STEMI system of care and improve this stuff that I described tonight. So what do we do next? How do we move forward as a state? Well, we need your help. We did a breakdown here of our centers that are VCSQI members and what parts of VCSQI they're participating with. So for instance, you can do STS and the surgical side, you can do CathPCI, and you can do the STEMI registry, or you can do any combination thereof. And you can see that we still have a long way to go getting centers, you know, involved in what I'm talking about, the STEMI registry tonight. Even centers that have been longtime participants with STS, the data use agreements to upload this data to participate, that is now part of the database contract. So we've tried, Eddie and Sherry have tried to make this as easy as possible. And I'm talking tonight about MI, but from Dr. Lancey's talk and from the talks that will follow me here shortly, there's a lot more that VCSQI offers. Everything from disparities in care to AKI to readmissions. So to me, this just makes my job as a quality improvement guy so much easier at my hospital. So when you hang up tonight or turn off your computers, if you're one of these hospitals that's not participating in all three of these things, really think about next steps. I realize there's some administrative and legal hurdles. You know, it takes a while to get this stuff done in hospitals, but really stay on these folks because we want you on board. We want you to be members. We want you to help us improve STEMI care in the state of Virginia in shock care. And I think that is all I have. Eddie, I don't want to monopolize, so I can wait for questions at the very end, or I can take questions now. Suggestions or anything else?
This is Bob. I just wanted to say thank you very much. And also to underscore something that you mentioned. For everyone, you can see the benefit of VHAC, and we are extremely proud of the new joining of VHAC with VCSQI, enhancing both of our missions into a larger common mission. I think the notion of trying to get the two databases together and re-emphasizing what Pete is saying about going to your health systems and making sure that you're working with VCSQI, whether you're with CathPCI or chest pain MI, or whether you're with the AHA, get with the guidelines. So merging that data can only help enhance the care we provide in our Commonwealth. So thank
Very
you.
well said. Thank you for that. And again,
Yeah.
thank you so much to VCSQI, Eddie, Sherry, all of the board's support. I feel like joining VCSQI was the best thing we did, and it's really brought VHAC and shock to a whole new level. So I think I will go ahead and present Eddie Fonner, who's our executive director. Eddie, I did not write down a detailed bio for you. I guess since we've worked together for a while now, I sort of took that for granted. But I will say that Eddie has just been an absolute dynamo. He's really been the thinker and the architect behind all of that, of what I present tonight with the STEMI registry. He's really got a sort of first-rate theoretical and statistical mind, and he's had to explain more than one statistical concept to me in the past. But I guess less of an introduction, more of a thank you before I turn it over to you and allow you to present more cost and quality data tonight.
Well, thank you so much, Dr. O'Brien, and we certainly couldn't do it without you as well. So we're just so pumped to have the partnership with VHAC and to keep this this train moving, and hopefully to get more centers on board here soon. But tonight, I'm going to speak more about the cost data, which is a piece that we haven't really touched in VCSQI in the last few meetings, at least. So thus far, we've heard some really great examples of how the clinical data can be utilized to improve patient care. And this is a slightly different facet of the database, and one that within our strategic plan speaks more to the improving value portion of VCSQI's mission. So we'll just put up the strategic plan here real briefly. With our mission of transforming cardiovascular care to improve patient experience and value. Again, how do you define value? And without the cost data, it's really tricky. So this is a unique piece for VCSQI, really, when you compare against other regional consortia around the country. VCSQI is still really the only one that is matching our clinical data with cost data. And at this point, we
look forward to seeing you tomorrow night.
We have a really extensive database on the clinical side, which includes the STS adult cardiac patient population with over 140,000 records. As Dr. O'Brien said, the CathPCI and chest pain MI pieces are being built, and there are already tens of thousands of patient records on that side. That's been driving our scientific publishing, our quality improvement projects, as well as the regular meetings and collaborative forums, much like this evening. But that can all be complemented, and the value of quality improvements in patient care can really be shown and demonstrated with cost data. So this is a slide from a number of years back. This demonstrated the additive cost of postoperative complications within VCSQI. And this is just for STS in this slide, but it showed the baseline CABG costs here of about $38,000. That's on a case with no complications or mortality. And then we layered some cost information on top of that, which showed the cost of a primary complication and the cost of a comorbidity. From AFib down there at about $7,000 for the primary cost, all the way up to renal failure at about $50,000, demonstrating the not just the quality improvement potential, but also the cost savings potential for our different initiatives within VCSQI. So we sought out to do a refresh and update of our costing algorithm, and this is all powered by the dynamic team over at Armis Health Catalyst, and specifically Zoltan Kurtzveil, who I believe is still on the line with us tonight. So Zoltan, thank you for all the hard work that's gone into these cost calculations. Here's a brief snapshot of how the data is matched and calculated. So first up is the acquisition of charge data. That comes from VHHA, the Virginia Hospital and Healthcare Association, who sends essentially it's a statewide inpatient data set of all hospitalizations within Virginia. They send that quarterly over to Armis. On the back end, that data is then matched against the clinical data, which is a multi-step process across several different variables within the two data files, dates of birth, MRNs, hospitalization dates, etc. So they kind of have a hierarchical way of matching, and have achieved some really great rates here, which you'll see in a second. Then once the data is matched, so we have clinical on one hand, we have financial on the other, there is a set of ratios of cost to charge. So over on the left side, it's raw charge data, raw billing data. These RCCs are calculated based on publicly available data from CMS cost reports. So essentially, those are different coefficients for different areas. So we have one for operating room, we have one for the ICU, we have one for blood, we have one for dialysis. All of those come from CMS based on their public data, which is hospital specific and year specific. So each of the, we're not painting with a broad stroke, we're actually zooming in and creating as precise estimates as we can for each category. So once those coefficients are applied, it transforms the raw charge data into an estimated payer cost. And these are basically a summary of the improvements that have been made in this algorithm. The cost data algorithm has been around for over 10 years now, but over the last 4 to 5 months, Armis has re-architected this. So they've revamped the data upload process from VHHA, which had some issues with file standardization, and we should have a much more rapid turnaround of data from VHHA and Heidi, who's their database vendor, going forward. They have completely overhauled the matching process. So previously, the STS data and the CathPCI data were housed in different sheds, so to speak. So we couldn't really apply the same type of matching algorithm across both registries easily. But now we not only have the STS adult cardiac data, but we have the CathPCI data, at least as a first draft, and we'll only get better going forward as we match across other new registries like STEMI and TVT going forward. And we have some new cost calculations. So as I just mentioned, we not only have adult cardiac surgery, we now have CathPCI, and we'll continue to kind of layer the different types of cost data for our different registries as we go forward. So let's jump into some numbers here. After all the kind of nuts and bolts of how this works, here is a summary of what Armis and VCSQI have been able to achieve over this most recent match of cost data. So for STS, we're looking at a longer time period. It's about 11 years worth of data, 75,000 cardiac surgery cases, of which nearly 95% of them have been matched. For ACC, we're just starting out with the CathPCI data, and this is over almost 5 years worth of data. As we only have the inpatient data from VHHA, we cannot really accurately match the outpatient data at this point, so that is one limitation. But we are still able to look at the inpatient data, which at this point is still, as we discerned a relatively high proportion of the cases. Had nearly 44,000 inpatient PCI that we were able to determine, of which over 16,000 were matched with the cost data. So that's just about just under a 40% match rate, and realized that that can definitely be improved. But this is just a first draft here, as we've gotten the cost data into production with CathPCI, and we still have tens of thousands of matched cases, and that will only improve as we go forward here. Here are the match rates by hospital. So as we see in STS, just about everybody is above 90% here. Most are kind of in that 96-98% range. There is one site here, I won't identify who they are, but they need to update their data use agreement with VHHA Heidi. We just haven't been getting the charge data for them. So that's one caveat. They once we get the data, we should bump them back up again. As far as CathPCI, you see some of the centers are actually close to 70-75%. It tails off on the right side here. There's one center that just for whatever reason has not been able to get a good match at all. So we need to go back and figure out, are they not submitting a certain type of either date of procedure or date of discharge, date of birth. Some of the different elements might not be available within their data set to match on. So we need to double check that and revamp some of the matching here. But again, there still are about 16,000 patients that we've been able to link up here within CathPCI. So what are the results of these matches then? Well, as we showed the initial slide, which had had additive costs for STS, here's just a quick refresh based on the latest data. This is the full 70,000 patients of matched data. So we have a similar breakdown. I wasn't able to delineate primary complication versus the secondary complications here, but we did a basic additive costing methodology where we took the baseline cost, which was still defined as a patient with no complication or mortality, and then defined an additive cost as the mean cost of a case with a certain complication or event postoperatively minus that baseline cost. So if the mean cost of a case with AFib is $45,000, we get that additive cost of $12K by subtracting the 33 baseline from that 45. So as we ascend to the right here, the additive costs increase, and we're looking at $70,000 to $80,000 of additive cost for reoperation or renal failure. So that is the STS side of things on additive costs. We're still pretty early on in additive costs for CathPCI, so we are going to add some more post-op event types within this breakdown here, but just wanted to show a quick teaser on how that would look. So similar type of baseline methodology here, where we have the cost of your average CathPCI case being about $21,000. When there's any incidence of AKI, and that's the the broad definition in terms of a 0.3 milligram per deciliter rise in serum creatinine, that adds $25,000 per case on average when you have a patient with AKI. In-hospital mortality adds about $33,000, and incidence of bleeding is $40,000 based on this costing methodology. So it almost triples the cost of a case when there's an incidence of bleeding. So that was the biggest learnings from this first round of cost matching. It's a work in progress at this point, so we will continue to refine both the matching, both the RCC application for both surgery and cardiology. We'll continue to add databases, with STEMI, with TBT, which also is up and running now within ARMIS. So those are our next steps. I don't know if I have time to give a demo of the ARMIS system itself, but I will say that this is a service that will be available to our VCSQI members who have ARMIS as their vendor. So the data will be available locally. You'll be able to look at your own patients in terms of looking at additive costs, looking at costs of care by category, for whatever data you'll have in ARMIS. You'll be able to look at that within the ARMIS kind of hybrid analytical dashboards that you should be familiar with at this point. So that's something I hopefully can demo here at one of our future meetings, or maybe on the quality committee, and can show you kind of how that works within the data. It's still in testing right now, but we hope to have that launched to the group here very soon. So that's an update from where we are on the cost data. Again, we're looking forward to continuing to add value to our VCSQI members with like literally with this cost data, and onward and upward as we move forward. So thanks all for being here tonight. I will pause for comments, questions on the cost data before we move on to our next segment.
So this is Bob Shor again. I just wanted to add how meaningful having the cardiology piece of cost. It is limited data from the inpatient side, but still the N is significant. It's very interesting to compare the prior STS data to the current STS data, and that's worthy of more review. This is the first time we're looking at the cardiology piece of cost as we go through and try to work at what are the impediments to getting more data. As you all know, this is the only place in the country where we are combining quality and cost data in a large area like this with the Commonwealth. So this is extraordinarily helpful and incredibly encouraging as we move forward with this information. So thank you to Eddie, and we all look forward to looking at this data in greater detail.
Thank you, Dr. Shor. Any other questions, comments? Very good. Well, we will be sure to be in touch and share the latest and greatest cost data after this meeting tonight as well with you all. So stay tuned. But next up, and our final presenter of the evening is Dr. Ray Strobel, who is a cardiac surgery resident at University of Virginia. Dr. Strobel is a rising star in our research and writing community. So the project you'll hear about tonight was selected as the J. Maxwell Chamberlain Award winner for perioperative and critical care at the 2023 STS annual meeting. Ray's just a great guy, and has really helped our research and writing committee move forward at light speed this year. So Ray, welcome. Thank you for being with us tonight, and take it away.
Well, thank you very much, Eddie, for that warm introduction. It goes without saying that our work wouldn't be possible without you and Sherry's efforts, as well as the support from the entire VCSQI community. So it's really my pleasure to talk about this project. Getting used to the latency here. So I have no disclosures tonight. As most of the folks on the call are very well familiar with, the COVID-19 pandemic continues to significantly and detrimentally impact our healthcare system. And within the realm of the VCSQI specifically, a recent study of the STS adult cardiac surgery base on a national level identified that within the first couple months of the pandemic's onset, there was a significant increase in risk-adjusted mortality for adult patients undergoing cardiac surgery. And the authors of this manuscript, as well as many of us, proposed a supposition that much of this observed effect has been due to a number of systems-level effects of the pandemic, namely delayed presentation of patients to cardiac surgeons due to fear of engaging with the healthcare system, difficulties with staffing that allows for procedures to proceed. Similarly, difficulties with obtaining the beds for postoperative care of said patients, and of course, shortages of critical materials and medications. Within the VCSQI, we have really established a strong body of evidence about socioeconomic distress and the impact that has on patients undergoing cardiac surgery. And we've done that, and I say we as a royal we, as I'm relatively new to the VCSQI. This has been a body of work that's been building over really the last decade. But the VCSQI has used a measure called the Distress Community Index, or DCI, to measure patients' socioeconomic distress. And that's been associated with 12% increased odds of mortality, increased morbidity, as well as heightened resource utilization for patients undergoing cardiac surgery. A little bit more about this very useful metric for those who are maybe less familiar. So the DCI is available for all zip codes in the United States with more than 500 residents. So that accounts for 99% of the United States population. And the way this index is built is data is fed into it via the American Community Survey, 5-year estimates, as well as the Census Bureau's county and zip code business patterns databases. And what that specifically means is that this index is calculated based off of an algorithm that uses 7 key variables. And those are high school graduation rates, poverty rates, the percentage of adults not working in that zip code, the housing vacancy rate, median household income, as well as change in employment and new businesses in that zip code. So very relevant variables for the socioeconomic vitality of an area. And ultimately, the index that's derived can range from 0, which is the least distressed community possible, to 100, which is the most distressed community possible. And as you can see on the included figure of the Commonwealth on the right side of this slide, there's a great deal of geographic variability in socioeconomic distress in our Commonwealth. Now, that all being said, while we have an understanding of how the pandemic may have impacted cardiac surgery patients as a whole in its first couple of months, and similarly, we understand that socioeconomic distress can be bad for patients after cardiac surgery in terms of their outcomes. What we don't really understand is how a patient's socioeconomic status may have differentially impacted how the pandemic influenced their outcomes. So did a patient who comes from a more affluent area versus a patient who came from a less affluent area, did those patients experience changes in care during the pandemic differently? And so that really was our study hypothesis here, that the COVID-19 pandemic is significantly associated with higher postoperative morbidity and mortality amongst patients who underwent cardiac surgery who reside in those more distressed communities. And so to investigate that hypothesis, we developed a cohort of patients undergoing STS index operations in our regional collaborative, the VCSQI, from 2011 through 2022. Our main exposure variable was, as we're discussing, the COVID-19 pandemic. And we chose a cut point or start point for the pandemic as March 13th. And that's based on when the federal government declared that the pandemic was a national emergency on that day. Our outcomes were operative mortality, postoperative complications, failure to rescue, which is death after one or more postoperative complications, as well as resource utilization. Our main effect analysis was multivariable logistic regression. And in order to address our question about whether socioeconomic status was changing how the pandemic impacted patients, we did an effect modification analysis to evaluate that differential influence of the pandemic by the DCI. So this is our consort diagram. We looked at just under 49,000 patients for inclusion, ultimately included 37,769 patients, of whom 7,269 underwent cardiac surgery during the pandemic. looking at our univariate characteristics of this cohort, so no risk adjustment, a couple big trends came out of that. One, we observed that patients undergoing surgery during the pandemic had significantly lower socioeconomic distress than those who underwent surgery prior to the pandemic. And similarly, patients during the pandemic had a lower STS predicted risk of postoperative mortality relative to patients who underwent surgery prior to the pandemic. So to distill that down, during the pandemic, the patients were more affluent and less sick. We then proceeded with our multivariable model, or models, as I will get to in the next couple of slides. And the first and most central model is that of odds of operative mortality. And so what we found is that after adjusting for several different covariates, including the patient's preoperative risk of mortality, time on cardiopulmonary bypass, the number of units of blood products transfused, as well as the distress score, the DCI, we found is that the pandemic was independently associated with risk-adjusted odds of increased operative mortality. And namely, that patients who underwent surgery during the pandemic had 40% increased odds of operative mortality relative to patients who underwent surgery prior to the pandemic. And this model explained a great deal of the variation in operative mortality in this database with a C statistic of 0.79, which is quite good. And it's important to note that we included hospital ID as a random effect, and that allows us to account for center level differences in practices which otherwise aren't included in the STS adult cardiac surgery database. And this is just a graphical representation of the prior slide. And as you can see at the bottom here on this forest plot, the pandemic era variable is highlighted. And this just underlines the magnitude of the effect that we observed in terms of the risk-adjusted association with operative mortality. We then looked at a couple of our other outcomes. And so this is the model, risk-adjusted model for failure to rescue, which again is death after a complication. And failure to rescue is really valuable because you can think of it as almost a measure of the quality of the team, the whole cardiac surgery team, because as many of us know, and I'm still learning as a resident, when a patient develops a postoperative complication, whether that's an ICU or step down urinary floor, or even after they've been discharged, it really takes the whole team, the whole community to come together, keep that patient stable, and then ultimately bend the trajectory back towards a positive outcome. And so what we found here was that even after adjusting for all those variables, patients who underwent surgery during the pandemic had significantly increased odds of experiencing failure to rescue, which obviously is a concerning thing. And lastly, we performed one other multivariable model, and this was looking at risk-adjusted cost. And perhaps not surprisingly, during the pandemic, there was a significant increase in risk-adjusted cost for patients undergoing cardiac surgery, almost $5,000 in terms of the magnitude of that increase. And so with all that established, we then took the next step and did the effect modification analysis, which again is to try and parse out if a patient's socioeconomic status is significantly modifying how, badly the pandemic impacted their outcomes after cardiac surgery. And what we found, surprisingly, was that it didn't significantly impact outcomes in that folks who came from more affluent communities versus those who came from less affluent communities seemed to do about the same, which was still worse than patients who underwent surgery before the pandemic. And we also did this sort of effect modification analysis for patient sex, race, insurance status, and age. And none of those variables seem to significantly modify the pandemic's negative effect on outcomes after cardiac surgery. And lastly, we were keen to try to address partially, if not completely, a gut feeling, maybe, and anecdotal evidence that many of us had that folks who were coming to the hospital and had a history of COVID-19 prior to being admitted and needed cardiac surgery, or even developed COVID during or after their cardiac surgery, were doing worse than folks who hadn't had the virus yet. And so, as our data managers are well aware of, the STS has included laboratory confirmed diagnosis of COVID-19 as a temporary field in the current running version of the database. And so we looked at folks who had patients who had a laboratory confirmed diagnosis of COVID-19, which was around 6% of the patients who underwent surgery during the pandemic. And what we found was that did not appear to be significantly associated with any of our outcomes, so operative mortality, major morbidity, complications, nor cost. And so it's always important to acknowledge limitations of your analysis and how those may impact the inference you can derive from your results. And so, as with any retrospective analysis, we're vulnerable to unmeasured confounding. You don't know what you don't know. And so variables that aren't collected by the STS and VCSQI cannot be included in our risk adjustment. Nonetheless, these results reflect a very rigorous risk adjustment and statistical approach to this question. We can't comment on the external validity of our results outside of the VCSQI. We studied patients in our Commonwealth. We didn't study patients from other states. And obviously the pandemic rolled out or impacted states at different times, or more severely at different times. Nonetheless, we included the entire pandemic essentially in this analysis. And also, as we discussed earlier in this presentation, Virginia is a very diverse state, geographically, socioeconomically, and so we do believe these results can be applied outside of Virginia. There is always a risk of misclassification of the patient level socioeconomic status with this approach because, as you may recall, the DCI is derived based on a 5-digit zip code, and a more accurate way would be to use a 9-digit zip code, but we just don't have that data available to us. And lastly, with any study of a procedural population, one weakness is that we don't know what happened with all the patients in the denominator. So the folks who were eligible for bypass or valve replacement and never made it to their cardiologist, or who were not offered surgery for one reason or another, we just can't answer the question of how did the pandemic impact them with the data we have. And so, in conclusion, our analysis found that across all socioeconomic statuses, the pandemic was associated with increased costs and greater risk-adjusted mortality, which we believe was driven by a higher rate of failure to rescue. And so we believe these results suggest a need for two things. One, continued mitigation of this pandemic's impact on healthcare by our policymakers and our health system leaders. And two, the need for evidence-based cardiac surgery protocols for resource-constrained settings, such as the COVID-19 pandemic, that will help us better adapt to and overcome the next event similar to the COVID-19 pandemic. And so with that, I want to say thank you for the opportunity to talk about this study. It really is an honor to get to work within the VCSQI, and I look forward to the discussion and any questions you may have. Thanks.
Great. This is Bob Lancey. That's outstanding. What a great presentation, and I applaud the work that you put into it. Much of it way over my head in terms of statistical analysis, but just outstanding. I have so many questions that I'm going to limit it to one, and that is the last sort of data point you presented, and that was that the failure to rescue rate you're attributing to the higher mortality rate. What do you attribute that to? Because I know you mentioned during the talk that you saw this as a sort of measure of team effort and team approach. Do you liken it to sort of dissolution of the team because of illness and healthcare providers, more travelers, less people available, or not to put words in your mouth, but what do you think is the cause of that? Why there was such a elevation of a failure to rescue rates?
Well, thanks, Dr. Lancey. Like I said, it really is an honor to work with this group, and I appreciate your kind words. I think it's multifactorial, and I would agree with all of the proposed causes that you just listed. I think it's changes in staffing, so folks that are leaving to travel or exiting healthcare permanently during the pandemic. It's the shortage of beds, as prior TCV or CTICU beds are being transitioned to take care of COVID patients during the surge. I think it's just sort of the tsunami that healthcare systems felt in terms of strain on their ability to function just on a day-to-day level, and that ultimately just made it harder for our kind of funnel approach or a Swiss cheese approach to getting patients through their perioperative period successfully. It just made that a lot more challenging, and unfortunately some patients were negatively impacted by that.
Yeah, I think it supports a contention I always had that a good cardiac ICU nurse is worth his or her weight in gold. They are the linchpins of what we do for our patients, and with the changes that went on and the stress they were under and all the moving around, I'm not surprised to see that there was a rise in failure to rescue. But again, great presentation. You well deserve the Maxwell Chamberlain Award. This is outstanding.
All right, this is Alan Spear. I'd like to just echo the congratulations on this very thought-provoking study. The one area that I'm the most concerned about, both in your presentation and then our observations in our institution, are the pre-op positive COVID group. It's unfortunate with the range that you looked at that we don't have a better knowledge in our Commonwealth on the subcategorization of the Delta patients versus the Omicron patients, because we know that there was a very discrete difference in their ventilator times and their morbidity. And so, what we, particularly in our ECMO group, the Delta did much poorer than the Omicron have done, but how that may have influenced the findings, particularly, and may have skewed the post-operative results. And was there any ability to differentiate post-op ventilator times, oxygen demands on those that were preoperatively positive? And did you have in your institution a algorithm of delay for how long you would wait toward the end, if their clinical status allowed? How long did you wait after they were positive or converted before you proceeded with either bypass or valve surgery? So again, congratulations, but I think that we're still trying to figure out how, and I have no idea what we'll do with this new variants that we're hearing about with Australia and China, because it's going to be, this is our new world, but our health center can't give us and won't give us out of Richmond the differential of what type of COVID it is.
Thank you, Dr. Spear, for the kind words. And certainly this research points out the need for just additional granularity on patients' COVID history, because as you said, not all COVID is the same. One size does not fit all. In terms of how the post-operative ventilation hours or prolonged ventilation was different based on a patient's COVID-19 history, if they had laboratory confirmed COVID-19. we did not see a statistically significant increase in prolonged ventilation amongst the patients that we looked at. However, I will say that these numbers are relatively small, right? We were talking about a couple hundred patients with laboratory confirmed COVID-19. We know a lot of patients may have, asymptomatic or not necessarily a very symptomatic presentation of COVID-19, but maybe they carry this burden of long COVID, and so they might not be captured by the laboratory confirmed variable. I completely agree that we're not done with this story. More study is needed, and we can't take our eye off the ball in terms of the granularity that is required to really understand this.
Good, thank you.
And if I could just make a plug, it's been really wonderful tonight hearing, Dr. Shor and Dr. O'Brien talk. And I did medical school in Michigan and was very involved in the MST-CVS QC there. And I completely agree with comments from others that one of the tremendous strengths of this collaborative is the true collaboration in one place, in one organization of cardiology colleagues and cardiac surgery colleagues. And so I within the research and writing committee, which of course this work comes out of, we have a couple of very engaged cardiologists, and we'd love to have even more. Clearly there's the opportunities for kind of multidisciplinary research are really blossoming right now with the cost data that's coming into play, and also the TVT database, which is coming up online. So if folks have ideas or proposals and are interested in talking about them, or maybe just need a couple of residents who have the determination and the willpower to help out, please swing by the committee meetings, and we'd love to hear your ideas.
Thank you so much, Ray, and great job. I'll echo your invitation to all of our members in VCSQI, cardiology, cardiac surgery, whatever your specialty. We want nurses there, database managers. Everybody is welcome at our research and writing committee. We also wanted to put out one new plug, as Dr. Shor mentioned at the beginning of the meeting. We do have a new biostatistician who is making her services available to VCSQI, Dr. Ting Wu, who is also from Michigan, actually. She will be serving on a couple projects to start with us, and we are currently taking proposals from the group. So please feel free to share any proposal you can think of with regards to how you can utilize the VCSQI data in an actionable way, in a way we can potentially publish on. And we will go through a formal review process, and Ting's services, as well as the other members of the VCSQI research committee, will be available to work on the project with you. So open call to anybody who wants to work on our R&W committee. Please reach out and feel free to share your ideas, comments, and thoughts with us. And I believe that was it in terms of our slides. So any additional comments, questions, discussion would be welcome at this time. Dr. Spear, I think you're muted.
In past years, we've always been together at this holiday time, and just certainly want to make a point of wishing everybody a very safe and happy holiday season. And what a pleasure it's been this past year to be associated, even if it's remotely. But we've made some great strides in spite of these challenges, and accommodated to the whole Zoom world. And so thanks everybody for your continued support and participation, and happy holidays.
Hear, hear.
Happy holidays.
Well, thank you to all our presenters this evening. Thank you to the VCSQI extended family for sharing your evening with us in the start of the holiday season. Beth has one question actually in the chat before we adjourn. She asks, will we be adding more detailed information for our COVID data fields, like a focus on timeframe inclusion, vaccine times, etc.? That's a question for database managers, Beth, but I think it would be really valuable from a research and quality standpoint. It's just a matter of, can we get that data from folks? We can add that to our list. I mean, we can certainly work with the talented folks at Armis and see if there are additional data points we can add in going forward. But great idea. Thank you for sharing. Well, with that, I don't hear any other questions or comments from the team, so we will adjourn. Again, thank you for everybody for joining us tonight. Merry Christmas, a joyous holiday season to everybody, and we will hope to see you in 2023. So thanks again, everyone.
Thanks all.
Happy holidays to all.